Actually, Manoj was my colleague at KU Meteorology, and we used to work together. So, as I told you, I am going to discuss a sensitive topic of thrombocytopenia, and we'll be going through some cases, and case-based discussion will be there. So, thrombocytopenia, when your patient comes to you, it is a difficult job. They do search online. The platelet is low, and what can I do now? Now, as half-life of platelet is 8 to 9 days, will I survive or not? Those are some silly questions they ask. And before we come in picture, there are three gays or three competitors we have. One is papaya leaves, then steroids, and Google. So, then hematologist will is there in thrombocytopenia. Okay, so moving on, history is most important. Before going ahead with any investigation, if we dig deep into the history of that patient, why patient is having such complaints, definitely we can go to the diagnosis. So coming to my first case, this is a 25 years old man. He had history of fever 10 days back. He was quite sick as per his complaints, and he had received some IV treatment at local hospital, and platelet count dropped on day 15 of his admission, and hence they called me up to have a look at him. This was his CBC picture. Hemoglobin was 11, WBC was normal, peripheral most of platelet count of 25,000, and large platelets were there. LDH was 400, DCT was 28. So I asked him, I asked the physician whether he has received some, because during admission his CBC was normal, and on day 15 he developed thrombocytopenia. So drug history I asked, and he was taking fibrosylin tazobactam. So because of fibrosylin tazobactam he developed thrombocytopenia. After stopping that drug, it improved. And we classically see after stopping the drug, the platelet count does improve beautifully, and if the drug is like fibrosylin tazobactam is there to stop it, definitely in a span of 7 to 10 days, the platelet count definitely improves. So 90% of thrombocytopenias can be concluded with the help of good history. So if you have good history, you can definitely give a probable diagnosis and then refer to a hematologist. So moving on to a curious case of thrombocytopenia. There was 35-year-old female. CBC was done by my friend Dr. Kalpesh. She had ghabra. So platelet count, he got platelet count on his machine 20,000. There was a panic from the family, panic from my friend Kalpesh. Then I told him on phone, ma'am, go ahead with platelet count in citrate or heparin. Again, platelet count came 15,000. There was chapter 2 of panic. So he called me, man, come and see the patient. So I said, just do one thing, send one peripheral smear to me. This was a peripheral smear. So peripheral smear has had clumps, and that was a classical case of pan-pseudothrombocytopenia. So this is the next level of pseudothrombocytopenia. In pan-pseudothrombocytopenia, you will get low platelet count with in EDT also, in heparin also, and in citrate also. So it is common after COVID pandemic. So pan-pseudothrombocytopenia, we are picking up more of pan-pseudothrombocytopenia patients. So peripheral smear does play an important role in diagnosing the cases of thrombocytopenia. Then my second friend, Dr. Rakesh, is a smart physician. He had a patient, 25-year-old female. She was PNC day 3. She had presented to him with easy fatigability, fever, headache, nausea, jaundice, and one unusual presentation, molecular UV. His CBC was ready. The patient had a hemoglobin of 7.3. WBC count was normal, platelet count was 20,000. For molecular urine, he thought there is some bleeding, so PTPT was done, which was normal. LDH came tremendously on high side, 7,000. Bilirubin was 5, indirect was 4, creatinine was 25, and haptoglobin was also done before I could see that patient. So Rakesh called me, he said, man, plasmid score is 7, you will have to come and see the patient. Okay, I see the patient and I ordered the peripheral smear only. Peripheral smear was classical history of microangiopathic anemia, quite a lot of schistocytes. We started her on plasma exchange, and this 13 was sent to AM Mumbai, and it came low. She responded within 5 seconds of plasma exchange. Moving on to the next case, when leukocytosis with thrombocytopenia. That was the next reference, and most probably when I get a call of leukocytosis and thrombocytopenia, I think probably it is a leukemia or leukemia reaction. But there was something going on in this case. So this lady, 42-year-old female, she had presented with fever for 3 days. CBC was done, hemoglobin was 12, WBC count was 35,000, neutrophilic predominance 79 neutrophils, and platelet count was 1,29,000, slightly on the side. Dengue antigen was positive. She had a stormy course, hypotension, recovered out of that. But on day 7, again she developed fever. Leukocytosis was persistent. Peripheral smear was seen by me twice, which was showing neutrophilic predominance. There was borderline thrombocytopenia. I thought we are probably dealing with secondary bacterial infection. Blood cultures repeated again, which was normal. She had a ferritin of 2,500, LDH was 750. Mostly in sepsis we can get ferritin of 2,500. She had a line. We thought we remove the line. Line was removed. Teeth was sent for culture, which bring staph aureus. It was sensitive to tegoprane, started on tegoprane. Fever was persistent on day 10 also. So we thought, let's not wait for blood culture, and we sent you that sepsis panel which grew enterobacteria, and also protein was positive. Started on septum asthma. Caspofungin was empirically added because fever was not budging on it. Fever was persistent, and she developed platelet count of 80,000 on day 12. We did bone marrow aspiration and biopsy after that. We get something like HLH or something, but we got hypocellular marrow. There was some cytopathic effect on marrow, and EBER was significantly positive. Why we did EBER receptor? Because a viral panel. We did viral panel for her, and on viral panel we could get Epstein-Barr virus with significant copies. So that was ABV related hemophagocytosis, and we started on IVIG and DEXA, but unfortunately we could not salvage it. So the return is we need to dig until we get the diagnosis. We at the even if we have lost the patient unfortunately, but finally we got the diagnosis why we lost that patient. So that is important. So coming to next case, this is a double whammy. In this case, the management, how did we manage this patient? I'm going to discuss it. So 16-year-old girl, she had presented with fever, rash, headache, thrombocytopenia. They thought it is a viral fever, dengue antigen, PCR was negative, platelet count was 20,000, hemoglobin was 8.9, RFTs were normal, LFT normal, bilirubin was just 1.5, and PTA was also normal. She had headache, so we did MRI brain. It was persistent. She developed cortical venous sinus thrombosis, and now cortical venous sinus thrombosis with thrombocytopenia, with post-viral. So we had all those EDs, but without coming to any conclusion, how to manage her now. We don't know the diagnosis, but managing her, how to treat her now, and how to anticoagulate her with such low platelet count was an important issue. Because whatever investigations we did, we could not get any reaction. Like AH was negative, EPA was negative, COVID-19 was negative, TTP was not there, DIC was also not there. But we had a cortical venous sinus thrombosis and thrombocytopenia. Then how to manage that? So we started on IVIG because platelet count was 20,000. We had to increase it as early as possible so that we could introduce the anticoagulation in the form of LWH. IVIG was started, MPS was also started. Platelet improved to 35,000 on day 2. We started LWH prophylactic dose. Day 4 platelet count was 1.6. We added warfarin, and again after tapering the steroids, platelet dropped. So we added on eltrombopag. At present she is on warfarin, and we are going to give it for 3 months. And with eltrombopag, her platelet count is stabilized to 1.5, and INR is to 2.3, and MRI is now normal. So this is how we can manage such a difficult cases where thrombocytopenia is there along with thrombosis. Okay, moving on to next case. Sometimes thrombocytopenia can come with a storm. This was a 30-year-old male. He had presented with right hypochondriac pain and swelling. CBC was done. It was showing platelet count of 90,000. WBC was pretty normal. LDH was 3,500. Uric acid was 13. CT abdomen, we did CT abdomen. CT abdomen showed a mass of 4 into 4 centimeter, right hypochondriac region. Biopsy then, biopsy was suggestive of 40% blast. This was the biopsy which showed CD20 positive, V was 100%. So, and CV was positive. It was a clear-cut case of Burkitt's lymphoma. So, mind it, we can get lymphomas along with thrombocytopenia also. So, getting good history, good physical examination is also important. Now, coming to uncommon presentation of a common disease. This disease we do, every one of us is treating on day-to-day basis. This was a 20-year-old boy, anemia, CBC had hemoglobin of 5, platelet count was 35,000. I am not putting MCV here. Bilirubin was 5, indirect was on high side, rating was 1. Again, LDH was 5,000. Peripheral smear had macrovalocytes, schistocytes, erocytes. What can be the diagnosis? Yes, megaloblastic anemia. So this was a picture of his knuckles, and it showed knuckle pigmentation, and peripheral smear had a good hypersegmented neutrophil. B12 was 45, and it was a B12 deficiency anemia. So B12 deficiency anemia, very severe B12 deficiency anemia nowadays we are seeing, it is presenting like a pseudo thrombotic microangiopathy. We are getting schistocytes on peripheral smear, we are getting thrombocytopenia, but B12 level is less than 50. So that is a classical presentation. Now coming to the hematologist bread and butter. ये हमसे कोई नहीं छीनेगा. So 20-year-old girl presented in emergency with ecchymosis, petechiae and hematuria. Physical examination, everything was normal except supplemental bleed and ecchymosis. CBC showed hemoglobin of 12, WBC was 8,200, normal differential platelet of 8,000, no other significant history. Peripheral smear was normal, TSH normal, HIV HBsAg, HCV negative. Yeah, so it's a clear-cut case of ITP. And in ITP, we all know mandatory investigations, CBC peripheral smear, good peripheral smear seen by a hematologist or hematopathologist, triple H and thyroid function tests are important. Don't do ANA or antiplatelet antibodies. Antiplatelet antibodies are banned. ANA only if you have a significant history suggestive of SLE, then only you can do it. What about bone marrow studies? Should we do it? Okay, so bone marrow aspiration biopsy is not indicated in ITP. When you should do bone marrow aspiration biopsy, if the patient is having pancytopenia, there are abnormal cells on peripheral smear, or if the patient has some hepatosplenomegaly or lymphadenopathy. In those situations only you can do bone marrow aspiration biopsy, and age is not a bar. Even if you have a patient of 70 years and platelet count 20,000, no other history and peripheral smear is normal, no need of bone marrow. So coming to the dengue-related thrombocytopenia, which is the most important thrombocytopenia nowadays. So this is the case, 20-year-old college student, symptomatic for fever, coming back, thrombocytopenia 35,000 on day 7. Dengue antigen was positive on day 1, PTA was normal. What a call. So IPF was the immature platelet fraction, which was 12, and I said as IPF is good, you can send the boy, and after 5 days you are calling for next platelet count. So after 5 days it improves. So what is IPF? IPF is basically a counterpart of reticulocyte count. Immature platelet we can calculate with the help of this IPF. And IPF, most of the machine, 7-part machine does have IPF function where you can get IPF value. So if you have IPF value of 5 to 7, or more than 7, then it is expected that your platelet will start rising. So if your patient's IPF is in an increasing trend, you expect the platelet count rise in 24 to 48 hours. If your IPF is going down, that means it is going to improve immediately. Like today, if your IPF, yesterday IPF was 12 and today it is 8, then you expect your platelet count will normalize up to 1 lakh. So IPF is a good indicator, but it is not necessary that you should do it only. If you have a facility, you can do it. And clinical management is most important. Date of fever is there, patient is febrile, platelet count is 35-40,000, and increasing trend is there. We can just do a platelet count and we can observe that patient. So how to manage activity? These are some questions I get regularly in my talk. So as we all know, the patient actively bleeding and platelet count is less than 10 or platelet count is less than 10,000, we can do platelet transfusion. Tranexamic acid can be given except urinary tract bleeding. Checking basic coagulation workup, PTAPT and fibrin is important, and the doses as per weight should be given. Platelet transfusion only if life-threatening bleeding for less than 10,000 or patient time for surgery can be given. What about SDP, RDP? What is the difference? We have transfusion specialist with us, Dr. Shashikan. He can also guide us, but there is not much difference except risk of reaction with RDPs is more as compared to SDP. The cost is 10,000 for SDP and RDP it is 400, 500. One SDP will increase your platelet count by 40,000 and RDP will increase your platelet by 5,000. Steroids. This is the most important issue. Should we use steroids in dengue or not? So CDC clearly says do not use steroid in dengue. There are some situations where we can use steroids, but not for every patient. If your patient has dengue 1 month ago and he is having thrombocytopenia, he is behaving like ITP, platelet count is still remaining less than 20,000 even after 1 month of dengue. In such cases, we can treat that patient like ITP. If platelet count is less than 30,000, patient is very sick, pancytopenia, ferritin is about 10,000, features suggestive of HLH is there, but you have ruled out sepsis and secondary bacterial infection. In that case, we can give and platelet refractory illness. Even after giving an SDP, if your platelet count is not rising by 10,000 or so, then you can suspect refractory illness. Provided you have checked the quality of SDP. SDP amount is adequate or not, that is also important. So in such rare situations, we can use it. Otherwise, in dengue, steroids are contraindicated. What about ferritin? We have seen a lot of legal cases also in Mumbai regarding ferritin and dengue. There was a case at just that the father alleged that ferritin was not done for him. But ferritin is not a marker which we should look at, only a marker we should look at, because there was some case series which was published, and here only 70% of patients with ferritin more than 50,000 had HLH. So only ferritin is not required. You should have pancytopenia, you should have such clinical pictures to suggest secondary HLH is happening or not. Also, you should have macro pictures. What about papaya and papaya leaves? That is most important part. So we do not have randomized control trial, a proper randomized control trial to prove the role. Then whatever studies are there, most of them are from India, Malaysia, Sri Lanka, and they have shown the platelet increment was around 24 to 30 hours before the other arm, which was not given papaya leaves or papaya leaf extract. Then we do not know about harm about the papaya leaf extract. There are studies which have shown some form of hepatitis and rash was there. Otherwise, no major issues, but not proven in randomized control trial. Standardization, we do not know is it standardized or not. What is the dose? Most of the time they have used 1,100 milligram 3 times a day for 5 days, but still we are not sure that is the adequate dose. There was another study from India, 500 different clinics, which had similar results, but not properly randomized. So there is a scope for research. There is something called caprine alkaloid in that platelet papaya leaves, which has role like it helps in increasing platelet count. That is proven rat model. So we do not have a clear picture as of yet to recommend papaya leaves in dengue and in related thrombocytopenia. So that was my last slide. Thank you so much.
Hello. It was an excellent presentation and very interesting cases. And the cases are very common, which we regularly see in our practice. So I really appreciate it.
Thank you, sir.
Some of the questions I wanted to ask you. Actually, I was surprised that you added papaya extract in your presentation. The comment is that in dengue particularly, this papaya extract or papayas are being prescribed or taken by the relatives. We know that in dengue, thrombocytopenia is not a problem. It's going to rise after 4, 5 or 8 days. So just wanted to wait and watch. The date doesn't happen because of the bleeding or pursuing severe bleeding. So I think you should not recommend it when knowing that it is going to increase over a period of time. Then I am practicing as an intensivist since last so many years. And I think thrombocytopenia is very common. Almost 30 to 35% patient at any given time has thrombocytopenia. And as you correctly said, antibiotic and preparative antibiotic which is used left, right and center, probably without knowing what infection might be due to viral infection, and it is one of the major causes of thrombocytopenia. Another common cause is, I think, heparin thrombocytopenia is one of the major causes which we come across. And there are a lot of other drugs which are actually causes thrombocytopenia that we should consider with treating the patient of thrombocytopenia.
Thank you very much for your wonderful lecture. You have cleared our main concept. At least we see the follow-up count is we are under stress. The follow-up count is less, then we are under stress. But you have cleared many points. And one more thing I would like to ask you: what is the critical value, or what I will say I would like to ask, which is a thing that is incompatible for the life? Because I have seen patients with 4,000-5,000, but they are okay. So what is your observation?
As you rightly mentioned, 3,000-4,000 also they are doing good, but it is like chronicity of that thing. If someone who is having a platelet count of 5,000 and he is not bleeding, that is okay. But someone who has presented day before yesterday to you and today his platelet count is 5,000, then this is not something we should only observe. There again we have to do this.
Thank you, Dr. Vasekar. Actually, this thrombocytopenia is very common for all physicians. What I see here is a good clinician to take a good history for each and every patient and a good clinico-pathological coordination. We don't have to run to Goldman, but rather than we should communicate with the pathologist and see a nice smear. Small things like hypersaturated neutrophils and a good smear and a platelet morphology can guide us. Plus the detailed clinical history, most common thing which we see thrombocytopenia is completely vegetarian patient not having milk and milk products is the commonest cause what we see for thrombocytopenia and thrombocytopenia. So we do need a clinical pathological correlation and do this.
Actually, in one of the case, you started a ticoplanine with a low thrombocytopenia count, which is another drug, I think, which
Yes.
causes thrombocytopenia.
Yes, true.
So, in such cases, how to actually decide?
Okay. So, gram-positive coverage is very difficult to take because vancomycin is most common drug after piperacillin tazobactam to cause thrombocytopenia. Second, linezolid is also associated with thrombocytopenia. So, out of these three drugs, I do prefer ticoplanine. And then, if thrombocytopenia is persistent, then I go ahead with vancomycin. And then third is linezolid.
The new drug which is actually marketed by Bukhar now,
Yes.
levonorgestrel, probably having no thrombocytopenic effect, but we are not confidently saying that it is very good and gram-positive coverage
Yes.
in present situation. But there is one other option available, or daptomycin, which is reality.
Yeah.
Does MPV have any role to play?
Yes, sir. As Manoj told that, in his lecture only, if MPV is on higher side, we know that precursors of platelets are coming in the blood circulation, and probably we are dealing with a destruction of platelets rather than production issue. So if MPV is on lower side, it gives us a clue that production is hampered.
Very nice presentation. I want to clear one doubt. The bone marrow biopsy or aspiration, is it contraindicated if the platelet is very low?
No, sir.
No, not at all.
No.
And if we get the platelet counts done at simultaneously or short interval, and there is a huge difference in that. So is it a lab error or something else?
Okay.
So I have seen one patient whose platelet count was 8,000 and the same day it came 1 lakh. So why this happens?
Sir, the difference of 10,000 is possible,
Yes.
but from 10,000 to 1 lakh, that means the machine was.
And is it good to send platelet count in repairable or irritable?
No, sir, EDT only. Only in those cases where you think pseudo-thrombocytopenia is the cause, then you can send it to citrate. If citrate may be available, then you can send it to repair or peripheral smell. You check the peripheral smell.
Yes.
You don't need to send it anyone.
Jeevan sir,
Yes, sir.
this is Dr.
Yes,
Sachin
sir.
Kale, I am a pathologist. This relates to us. The most important cause of this variation in platelet count is sample collection
Yes.
technique. If it's a difficult venipuncture or sample is collected from arm receiving IV fluid, this is bound to happen. So repeat sample for any unexpected platelet count, any variation is very important.
Right.
Thank you. I was thinking actually, but I saw this is related.
Thank you, sir.
One more thing which I am observing is that we get a thrombocytopenia in critical ill patient, and usually sepsis is a blind diagnosis for thrombocytopenia. But sometimes we really miss some autoimmune disease, and that is only actually trigger to think that we are missing some other diagnosis. Yeah, and the case which you shown that you lost this case, I was not sure what is the diagnosis of that.
EBV related hemophagocytosis, secondary hemophagocytosis with EBV infection that triggered after dengue. She was not having any lymphadenopathy because CT was done and CT was done. But, and it was like her fever was not going only, so I thought I'll go ahead with marrow and we'll do viral panel also. So we got EBV and even on biopsy.
So for all of us, can you tell when to suspect HL?
Okay. So HLH, suspecting HLH is if your patient is having fever, continuous fever. Second thing, patient is having pancytopenia. Third thing, if your ferritin is going beyond 10,000. Fourth thing, splenomegaly is there. So in these 4 criteria should be there to suspect an HLH. And if it is there, you just call one of those patients compared to the man.
Suspected megaplastic anemia.
Yes, sir.
What is the better approach to do serum B12 level, homocysteine, or hopefully as a routine?
Okay. So, suspected megaloblastic peripheral smear is best. If we want to prove it that B12 deficiency is there, majority of most of the time they do receive B12 supplement from outside. So we do get normal B12 level. So in that case, we can send homocysteine, which will be on higher side. Third thing is methylmalonic acid can also be done, but that investigation is costly. So both these investigations can be useful in proving megaloblastic, but peripheral smear is the key to diagnosing megaloblastic. And IDW and high MCV, if you have high MCV with high IDW, definitely we are dealing with megaloblastic. Okay. Thank you.
Thank you, Vasikar sir, for this wonderful learning session. I request Archana Kabra madam to felicitate our speaker, Dr. Vasikar sir. Tushar sir, please felicitate Nikaja sir. Sir. Dr. Archana madam. I request Jeevan sir to please come on the dais. Thank you, chairpersons, for chairing this session.